and welcome to today's Public Health Ontario Rounds presentation on opioid-related toxicity, death, and health service use during the COVID-19 pandemic. My name is Pam Leese. I'm a public health physician at Public Health Ontario, and I have the pleasure of moderating the session today. And I have no potential conflicts of interest to declare. Just a little bit of housekeeping before we start. The chat pod has been disabled to limit any distractions. There is the question and answer pod. If you have questions during this session, please populate them there. We will have a question period following the presentation. At any point, if you have technical issues, you can email capacitybuilding@oahpp.ca. Before we begin, we want to acknowledge the land that we're hosting from today. I recognize my position as a white European settler background, and I have an ongoing commitment to learning, reflection, relationship building and action in the work that I do. We acknowledge this land that we are meeting on as the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, Haudenosaunee, and Wendat people, and is now home to many diverse First Nations, Inuit, and Métis people. We acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. We also have an acknowledgement of people who use drugs as we begin. We recognize the expertise, strengths, innovation, and leadership of people who use drugs have been central in developing and implementing programs and services to respond to the overdose crisis, and recognize the many lives lost and impacts on people and communities over the years, and more recently during the pandemic. We'll pause for a brief moment of silence just to arrive to this topic and reflect on the ongoing impact in communities and acknowledge people that we are thinking about or remembering. And I specifically want to recognize our colleague, Randy Roberts, who passed away last week, and his leadership with the Brantford Substance Use Network and the Ontario Network of People Who Use Drugs. So we'll just take a moment to pause. Okay, thanks everyone for being here today and the opportunity to discuss this important new report released today. It's a heavy topic, so take care of yourself and feel free to step away as needed. I have the pleasure to introduce our three speakers who will speak to our topic in sequence. So Tara Gomes is an epidemiologist and principal investigator at the Ontario Policy for Drug Research Network, Ontario Drug Policy Research Network, Tara. Jillian Kola is a postdoctoral research fellow at the Canadian Institute for Substance Use Research at the University of Victoria, and Jess Bashera is a substance user who provides peer support and outreach in her community. And so I'll turn it over to the three of you, and then we'll have time to discuss after. Thank you.
Thank you, Pam. Really appreciate the introduction, and thank you for inviting us to present some of the findings of our report today. And thanks to all of you for joining us. Before we get started, I just wanted to add to what Pam had mentioned just around the content of this report and the fact that we wanted to make sure we did take a moment to acknowledge all the friends, families, and loved ones of people who were lost during this overdose crisis in Ontario and more broadly just across all of North America. And I think it's sometimes a bit challenging for us because we talk a lot about data and statistics on this topic. And it's just so important, I think, for us to ground ourselves in remembering that embedded within this data are those stories of huge amounts of loss and grief for many people across our province. And a lot of people are also having to deal with this grief and loss and trauma during the isolation that we are all experiencing during this pandemic. So, as Pam has already done, we just wanted to take that moment to address the fact that we acknowledge that this report can't in any way adequately reflect the burden borne by people who have lost loved ones across the province. And we do try to make sure that we are keeping that in mind and considering all of these stories and all of the grief and trauma that people are experiencing during this time as we reflect on this work. In terms of disclosures, none of myself, Jillian, or Jess have received any financial support or in-kind support from commercial sponsors, but we do have some disclosures that we wanted to make sure were clear. All three of us in different ways have received funding largely to help support some of the research that we do in this area, largely from public drug funding sources. And we have all been involved in different capacities as external consultants or advisors on a number of different committees at the local, provincial, and national level. The presentation today has been peer-reviewed internally at Public Health Ontario to make sure that what we are presenting meets the principles of scientific integrity, objectivity, and balance, and trying to mitigate any potential bias. So I will just get started here by talking a little bit about some of the background. So how we got to pulling together this report. And it really started when the pandemic arrived in Ontario, and many of us who work in this area were quite concerned about the impacts of the pandemic and some of the responses to the pandemic on the overdose crisis that we were already so concerned about. And so since that time, many of us have been working to try and better understand the circumstances around opioid-related deaths and how they have been changing during the pandemic, to try and help make sure that we're generating evidence and information that can make sure that Ontario and more broadly across Canada is responding appropriately to what has been changing as COVID-19 has complicated our overdose response. Our last report, which was released in May of last year, in which you will see some elements of sprinkled throughout this presentation, really focused on looking at the data that comes out of the coroner's investigations to try and better understand things like what types of drugs were involved in opioid-related deaths, and some more information around employment status and location of residence and location of overdose, and also had a focused analysis among people who are experiencing homelessness, because we have seen that this is a population that has been disproportionately impacted by this crisis during the pandemic. And we found that that was a very helpful starting point for us to better understand what was changing as the pandemic arrived in Ontario. But it also opened the door to a lot of further questions that we felt was really necessary for us to gain a better and more complete understanding of what had been changing. And so that is what we have built into this newer report, where we are trying to spend a bit more time doing more rigorous analysis, understanding the role of pharmaceutical and non-pharmaceutical opioids and other drugs to the overdose crisis. And then in particular, trying to better understand how people are accessing healthcare and where there might be barriers or missed opportunities for supporting people who are at risk of overdose and who have had a fatal overdose during the pandemic. And finally, there are a lot of other pieces of information that we can glean by trying to understand some of the other clinical diagnoses and reasons people may be interacting with the healthcare system. So that's another element that we felt was important to build into this work as well. And I won't spend any time beyond this slide on methods, but just to give you an idea of where this data comes from, we created two cohorts. We looked at people who experienced an opioid-related death during a pandemic period, which was essentially defined from March 17th, 2020, when the state of emergency was declared in Ontario, to the end of that year, and then constructed a comparison period, which is essentially the exact same dates from the year prior, so that we could compare some of the trends and patterns between these two groups of people who had died of opioid-related causes, both before and during the pandemic. And then what was really new in this report is that we then linked it at ICS to a number of different databases, including prescription opioid data that includes opioids indicated for pain and treatment, physician services, emergency department visits, and hospital stays, both in acute and mental health settings. And just before I launch into a lot more of the detail of the report, I'm guessing that most people who are on this call and joining today are pretty aware of how the trajectory of opioid-related deaths has changed over the past many years. But just so that we're all kind of grounded in the same information, this is a trend of opioid-related deaths across the province just over the past 3.5 years prior to 2020. And what we saw was that there was this immediate acceleration in the number and rate of opioid-related deaths that occurred soon after the pandemic arrived in Ontario. And in fact, there was about a 79% increase in the number of opioid-related deaths between February and December of 2020. So we did see this immediate impact of the pandemic on the crisis that many of us have been working on for quite some time. And there were many reasons that we can discuss around why we anticipated that this would happen, including changes in the way that people were interacting with the healthcare system and the way the healthcare system was being provided, different supports and community-based programs that might no longer be accessible to people who relied on them for safe spaces to use drugs, or even just networks of support and peer support. And then also, one of the main public health responses to this pandemic has been a focus on physical distancing. And obviously there are a lot of concerns around the risks of using drugs alone, and a lot of concerns that as the pandemic evolved and people were not able to gather in the same way as they had before, that could increase the likelihood of people experiencing fatal overdoses. So, a lot of this rise, unfortunately, was not totally unexpected. And what we've been trying to do is better understand what those factors have been that have been driving this increase so that we can improve our response. One of the first places we often look at is demographics. What we've seen, interestingly, is there hasn't been a huge shift in the demographics of people who are being most impacted by this crisis. It continues to be one where people who are between the ages of 25 and 44 and men have much higher rates of opioid-related deaths. However, it's really also important for us to recognize that this is an issue that crosses all demographic profiles. So we are seeing people dying of opioid-related causes across all ages and across men and women. And so we need to think about broad access to a variety of services, while also keeping in mind that men and kind of younger adults are a population that are often disproportionately impacted by the overdose crisis. Despite starting with demographics as a place we often start when trying to understand what's happening with an issue that we're grappling with, there are other elements that I think are more important when trying to think about how to have an effective response to this. And these include understanding where geographically these deaths are occurring across the province, so that we can better understand where to make sure services and supports are provided. And then thinking about what kinds of services are needed. So what are the drugs that are driving these increases that we're seeing, so that we make sure that the suite of services and programs that are being provided are tailored to those needs. And then if we are providing these services, what are the specific settings that we should be putting them into? So where are people who are at most risk of having an overdose or having an opioid-related death? Where are they interacting with, and how can we make sure that we then integrate services directly into those settings? And these are the kinds of questions that we've really tried to focus on in this report. So if I start on the geographic side, I think that one of the things that has been a large focus of some of the response to this crisis has been providing services in many larger urban centers of Ontario, largely in the southern part of the province. And it's understandable because that's where the largest absolute number of opioid-related deaths tend to occur. However, in this report, where we look at population adjusted rates, so taking into account the total population size within different regions, I think it's really important for us to appreciate the fact that the actual population adjusted rate of opioid-related deaths is very similar between urban and rural parts of this province. And so this really highlights the need for us to think about how we can more broadly distribute and distribute investments into parts of the province where they may not have the same level of financial resources right now to provide access to services, but are grappling with an epidemic of overdoses that is really similar to what we're seeing in some of the larger urban centers as well. It's also really important when we look at what's happening in Northern Ontario, where we see that the rates of opioid-related deaths is about 3 times higher than in Southern Ontario. So while the absolute number of deaths might be lower, the fact that we are seeing such a huge impact in many northern, rural, and remote communities of the overdose crisis reiterates the need for us to really think about how we can better provide services to some of these communities. And this was really reinforced in our last report, where we looked at these rates by health unit and saw that the parts of Ontario with the highest rates of opioid-related deaths were really, Algoma, North Bay, and Thunder Bay, Sudbury regions. So these are a lot of parts, particularly of Northern Ontario, that are struggling a lot, and we need to make sure that adequate resources and access to services are being implemented and provided there. And a lot of that comes down to funding. There are a lot of people in these communities that really want to provide these services, and we need to make sure that we're providing those resources and funding to support the implementation of that work. And so that brings us to the question of what types of services are needed, and trying to kind of disentangle the roles of different drugs into this ongoing crisis. One of the reasons that we wanted to do this is, there has been historically a large focus on the role of pharmaceutical or prescription opioids to overdoses and overdose deaths. And a lot of the drug policy response has been predicated on, promoting appropriate prescribing and making sure that prescription opioids are being prescribed as safely as possible. However, I think that one of the huge concerns that many of us have is that thinking has not evolved. It has not changed in response to what we are seeing in the overdose crisis right now, which is that this is a crisis that is predominantly one of non-pharmaceutical opioids. And that is increasing during the pandemic. So we had found during our pandemic period that nearly 80% of all opioid-related deaths involved only non-pharmaceutical opioids. The vast majority, about 99% of these, were fentanyl deaths. So it's really important for us to really focus in on the fact that this is a crisis of the non-pharmaceutical drug supply right now. There were only 1 in 10 deaths that involved only pharmaceutical opioids during the pandemic. And you can see how much that proportion dropped during the pandemic as well. And that was really just because essentially all of the additional deaths that we have seen during the pandemic have been from the non-pharmaceutical opioid sources. And that ties in directly when we go back to our last report and we look at the types of opioids involved in death. And again, 90% essentially of the opioid deaths during the pandemic involve fentanyl. And so this just reiterates the fact that this is a non-pharmaceutical drug issue, and one that is really predicated on the fentanyl that we're seeing in the unregulated drug supply. We do see some other prescription opioids that do come up and are contributing to some of the deaths that you can see on this figure. And so we did want to delve a little bit more into some of these elements. And one of which was just looking at how many opioids are involved in death. So when somebody has an overdose, is it because they're taking a combination of multiple different types of opioids, or is it that it's typically just one opioid that is contributing to that death? And so when we looked at that, we essentially found that this is, again, very much an issue where most of the deaths occur with only one opioid that is involved and directly contributing to the death. And so if you kind of bring this all together, you start to see this pattern of, this being an issue of the non-pharmaceutical drug supply, where it's fentanyl that is directly contributing to these deaths. And most of the time it is just fentanyl. It is not fentanyl with other opioids. We were able to look at whether people had received a recent opioid prescription as well, to just try and see, whether there is any role or what that role is of prescription opioids among people who had an opioid-related death. And we saw that there has been a reduction during the pandemic. So there were about 1 in 4 opioid-related deaths where people had a recent opioid prescription dispensed to them from a pharmacy. And so that was in the past 30 days prior to death. However, what was really important when we looked at what opioids were dispensed, about half of the time it was methadone. So this is largely, even when people are being prescribed opioids, they are being prescribed opioids to manage an opioid use disorder, and less so opioids to treat pain. And we focused then a little bit more on those methadone involved deaths because we wanted to try and better understand what was happening, because obviously methadone is one of the gold standards for treatment of substance use, of opioid use disorders. And we found that about 2/3 of people had recently been prescribed methadone, which is not surprising. But when we looked at the doses of methadone that were prescribed close to death, we found that the median dose was about 70 milligrams, which is actually quite a bit lower than some of the recommendations for doses that are made right now for people who have been previously exposed to fentanyl. And about half of these deaths also involve fentanyl. So I know that Jillian will talk a bit more about this later, but I think it's really important as well to try to start to understand where there might be ways in which we can improve access to treatment, as well as we're considering people who are having overdoses that involve methadone. We also have to remember that this is not a crisis of opioids alone. So we are able to look at some of the other opioids that are involved in fatal overdoses in Ontario. And two of the drugs that really are commonly found and I think give us a lot of information as to where we need to start building our response are related to benzodiazepine and stimulants. And this is for very different reasons. So as it relates to benzodiazepines, we're largely seeing overdoses that involve non-regulated benzodiazepines. These are drugs that are not regulated for sale for prescription in Canada, but are instead actually entering into the unregulated drug supply. And this was a trajectory that we had seen prior to the pandemic as well, but it certainly has accelerated much more quickly, such that during our pandemic period, 1 out of every 4 opioid-related deaths that occurred also had tizolam, which is the most common non-prescription benzodiazepine that is in the unregulated drug supply, that were also being detected in these deaths. So there is a lot of overdose that is occurring among people who are being exposed to both tizolam and fentanyl in the unregulated drug supply. And that's challenging for a number of reasons, including that this can, the highly sedating effects of the benzodiazepines in particular in combination with opioids can complicate the overdose response. We also know that when people enter into treatment, for example, with methadone, the methadone will help replace the opioid that they were accessing from the unregulated drug supply, but not the benzodiazepine. And I think there are a lot of concerns about what that means in terms of having people go into benzodiazepine withdrawal when they enter into treatment and how we can better support people who have been exposed to such large amounts of benzodiazepines in the unregulated drug supply. And then finally, there's a fair amount of evidence in the pharmaceutical benzodiazepine literature around the longer term adverse effects of benzodiazepine use. And so one of the concerns that I have is thinking about the number of people who are being exposed to large amounts of benzos in the unregulated drug supply right now, and what that means not only for their short-term health implications, but also over the longer term. And then we've also looked at stimulant involvement in opioid-related deaths, and this is more of an issue or a question of polysubstance use. And the fact that we are seeing more than half of opioid-related deaths also involve drugs like cocaine and methamphetamines means that our response needs to also take this into account. And when we're thinking about the kinds of services that might be needed, we really need to consider multi-pronged approaches that respond to the needs of people who use drugs and the fact that they might need places to safely inhale drugs and to safely use stimulants as well as opioids, as well as thinking about safer supplies of stimulants, because it's clearly a lot of polysubstance use that is occurring and many people who are experiencing harm and fatal overdoses when using both opioids and stimulants. So that gives us a very quick understanding of some of the different drivers in terms of the types of drugs and the circumstances in which these drugs are working together to increase the risk environment for people who use drugs. And it gives us a really good indication of the kinds of services that are going to be needed, including not just treatment, but harm reduction programs, safer supplies of drugs so that people are not reliant on the volatile, unregulated drug supply right now, as well as safe spaces to use drugs, particularly during a pandemic when it can be very challenging to kind of gather together and have peers and others available to intervene if you do have an overdose. One of the other elements then becomes, where do we incorporate these services? And we really wanted to get a better idea of how people were engaging with the healthcare system, especially in those days and weeks prior to death, to try and understand where we can better provide services to people who are at risk of overdose. So one of the first things we did was simply look at people who had a fatal overdose and look back in the past 7 and 30 days to see if they had had an encounter with the healthcare system. And we defined this as basically any visit to a doctor's office in an outpatient setting, as well as visits to emergency departments or having been discharged from an acute or mental health hospitalization. And we found a few things here. So first of all, we did see that there were reductions in engagement with the healthcare system during the pandemic compared to the year prior. And I think that that is very aligned with what we just saw more broadly across the province during the pandemic, where people were less likely to engage with the healthcare system. There's more hesitancy to go to hospitals or some other barriers in terms of accessing outpatient care. There's also a concern that a lot of outpatient care switched to virtual care, and what that might mean for a population of people who may not have regular access to technology and even regular access to a phone. But the other really striking thing that I think many, if not all of us who worked on this report were struck by was that there's a high degree of interaction with the healthcare system very close to time of having a fatal overdose in this population. And so, the finding that half of people have had some kind of contact with the healthcare system in the last 30 days and 1 in 4 in the last week prior to death is really striking, and I think identifies a really important potential missed opportunity to provide care and to support people who are at risk of overdose within these settings. And so we wanted to try and better understand where people were actually engaging with the healthcare system across these settings. So we first looked at outpatient visits, and within this analysis, we were focused on essentially any visit to a doctor's office, and we saw that again, there was a significant decline overall during the pandemic, which I think aligns with perhaps that shift to virtual care, as well as just other barriers to accessing care in general during the pandemic. But it was still pretty high, with nearly 1 in 5 people having engaged with a doctor in an outpatient setting during this time. We also looked, although it's a small number, at people who had an active methadone prescription at time of death, and saw that there were much higher levels of engagement with outpatient care within this population, which makes a lot of sense because of the very, very strict requirements that are part of most programs to have people regularly go to clinics. And I think if nothing else, what this shows us is that there is a lot of opportunity within these clinics and among people who are within treatment programs to provide them with support and to provide them with connection with other services. And so there may be opportunities for us to improve that. If we move to hospital-based settings, what we really found was that there also is a lot of contact across a number of different hospital-based settings, be it emergency departments or some kind of hospitalization. And in many cases, in particular among ED visits, those interactions did decline during the pandemic. However, the breadth with which people are accessing these different services just in the week prior to death means that we really need to think beyond just providing access to treatment, for example, in outpatient settings and harm reduction, but also integrating either direct access to some of these supports into hospital and emergency department-based settings, or ensuring that we have referrals back to community for people who are interacting with the healthcare system in this way. The other thing that does stand out as important in this analysis was our finding in hospitals, where we did see that there was a rise in people who had been admitted to hospital or mental health hospitalization in the week prior to death during the pandemic. And I think this could reflect that perhaps if people are less likely to be engaging with care in an outpatient setting, and might be more sick when they come to hospital and therefore be more likely to be admitted. But this also ties in with some of the other characteristics that we saw, where we saw that there were significant increases in outpatient visits and hospitalizations related to schizophrenia and trauma-related disorders like PTSD. And I think that this likely reflects some of the destabilizing effects of the pandemic, which can be particularly challenging for people with some mental health diagnoses like schizophrenia, who rely really heavily on supports and services that are provided in both healthcare and community-based settings that have been disrupted during the pandemic. So this really speaks to the need for us to better support people with concurrent diagnoses of mental health issues, along with those who are at risk of overdose, to make sure that they're receiving the supports that they need within our healthcare system. We also saw, and it's not unexpected, that there was a high degree of people who had substance use diagnoses within our cohort. And we wanted to focus in more on this. So we looked at what proportion of people had an opioid use disorder diagnosis, and found that about 2/3 of people did have an indication of healthcare contact related to an opioid use disorder prior to death. And I think that there are a few things that we need to consider about this. First of all, I think the fact that 1/3 of people had no indication of an OUD diagnosis is really important, because oftentimes we really focus on the potential access to treatment as one of the main ways of responding to this crisis. And the fact that there's a not small proportion of people who likely don't have an OUD diagnosis and are probably occasional users of drugs and are at risk of overdose is something that I think is often overlooked, and means that we can't rely only on treatment, but have to supplement that with other harm reduction services that are accessible across the really diverse population of people who need it. And Jillian will speak to this more as well, but just the fact that 2/3 of people had an OUD diagnosis, but only 1/3 of people had had any access to treatment in the last 5 years is a really important finding, and speaks to our need to think about how we're providing treatment in this population. So just in closing, I'll just quickly describe our focused analysis among people experiencing homelessness. We wanted to look at this because of the disproportionate impact of the pandemic on this population, and the fact that 1 in 6 opioid-related deaths during the pandemic were occurring within this population. And some of the main findings that I think are important to highlight are the fact that many of these deaths occur in shelters, supportive housing, and some of the hotels that have been set up as emergency shelters during the pandemic. And so we really need to think about meeting people where they are and integrating these services more broadly into these settings. And then finally, we've seen that there's a high degree of healthcare interaction and engagement as well in this population, but it happens in different ways. There's much higher percentage who have engaged recently in the emergency department. And we see higher rates of OUD and mental health diagnoses, with even worsening trends towards more contacts for schizophrenia and PTSD in this population. So just to reiterate the fact that within this population that's already having so many struggles during the pandemic, and where we are seeing so many opioid-related deaths, we also have to make sure that the services that we're providing are meeting them where they are and are meeting the complex needs that many people who are experiencing homelessness have. So at this point, I am going to pass it over to Jillian Kula, who's going to talk a little bit more about the broad implications and community response to this issue.
Thanks so much, Tara. And if we can go to the next slide. So in discussing the implications of these findings, I wanted to start with the levels of service use we found in this study. Often there's an idea that people who are at risk of overdose or who are dying of overdose are disconnected from the healthcare system. And that is often very true and must be held into account. But we found a relatively high proportion of people having interactions with the healthcare system in both the week and month before they died. And I do have to admit that I was a little bit surprised about the amount of health services use we found, as this likely represents a very strong opportunity to intervene with people who are accessing healthcare services to reduce their risk of overdose death. On the other hand, I do a lot of qualitative research with people who use drugs, particularly on the impact that the overdose crisis is having on their lives. And it's very common for people who use drugs to tell me, for example, they went to an emergency department after having had an overdose and they received no information about the medical treatments that might be available for them, like opioid agonist treatments. They received no referrals to community harm reduction services. And they frequently also report high levels of stigma from healthcare providers and often outright discrimination. So I think we need to be thinking about how to ensure that when people are interacting with the healthcare system, and we see quite a few of these interactions, that they receive the connections that will be best able to meet their needs. And I think that concurrent to that, we also have to be thinking about how we address the high levels of stigma and discrimination within the healthcare system that might also be interfering with the provision of the highest quality care to people who use drugs and who are at risk for overdose. Next slide, please. Another surprising finding in the study that Tara alluded to was the fact that while 66% of people who died of an overdose had an indication in their interactions with the healthcare system that they'd been diagnosed with an opioid use disorder, that still left 1/3 of people who did not. And I think this is important because there's often a conflation that happens between opioid use disorder or addiction and risk for overdose. And there's clearly a strong connection there. But one of the things that this finding points to is that there's likely a substantial group of people who are intermittent opioid users, so people whose pattern of use is more recreational or occasional, and who are nonetheless at high risk of dying from opioid overdoses due to the toxicity of the unregulated drug supply that is primarily composed of fentanyl. And I think that this is important, as this is not a group that would necessarily qualify or be interested in treatment. And I think this speaks more broadly to the fact that we need a very very wide-ranging and comprehensive response to the overdose crisis that includes not only access to treatment, but also a strong access to harm reduction interventions like supervised injection sites, as well as supervised inhalation or smoking sites, of which we have none in Ontario, as well as thinking about the regulatory measures that would intervene at the level of the drug supply that would ensure that if people are occasionally using opioids, they have access to an opioid of a known dose rather than only through the unpredictable and unregulated drug supply. Next slide, please. I think it's also important, excuse me, that there were relatively low rates of opioid agonist therapy prescription among people who died of an overdose, with only about a third of people having a prescription for methadone or buprenorphine in the 5 years before they died. This drops even lower when we look to the month before death. And I think that we really need to think about how to remove barriers to access to OAT treatment, because clearly we want to make sure that as a treatment that has been shown in repeated studies to reduce the risk of overdose death quite significantly, that it's available and accessible to people who might be good candidates for it. But I think this also speaks to the need for a broad, for consideration of a broad variety of responses, including safer supply for people who OAT has not worked for or for whom they're not interested in OAT. And just as an example, we've known for years that while retention in OAT treatment varies, less than half of people who started are retained for a year, and this is likely dropped in the fentanyl area. So we really need to think about how to improve retention in OAT treatment. And I think that one thing that's important here is to think about how it's been difficult sometimes for people who use drugs to have their concerns around the delivery of OAT listened to. And during the pandemic period, one of the criticisms that people who use drugs have frequently had has been around the strong restrictions around take-home dosing policies. And during the pandemic period, we had those restrictions lessened. And it turns out that it actually somewhat increased retention with no additional harms. And so I think that this was a place where people who use drugs have been trying to tell us for years what would work better for them and increase retention. And we just had a bit of a real-world example that showed that it really actually did work. Next slide, please. So I'm going to speak a little bit now about the role of methadone. And I think it was somewhat reassuring that methadone was only involved in a small number of overall overdose deaths. And this proportion didn't change much during the pandemic. And this is important because there was concern that loosening the take-home dosing requirements during the pandemic may lead to an increase in harms in the community. And I think that one important note here is that people who are prescribed methadone who died are on what would be considered to be fairly moderate doses in the fentanyl era, and that 55% also had fentanyl as a direct contributor to death, which suggests that the methadone they were receiving was not meeting their needs and that they were using fentanyl from the unregulated drug supply to supplement. I think it's also important here to note that about 2/3 of people who had methadone contributing to their deaths had a prescription for methadone, and 1/3 did not. And I think this comes back to the access issue. We need to ensure that OAT treatment is being easily accessible and available for people so that people who need access have access to it through medical sources. Next slide, please. I just want to highlight, as I finish off, that really the continuing volatility in the unregulated drug supply is a major issue. Overwhelmingly, people are dying from fentanyl from the unregulated market, and increasingly fentanyl is the only opioid detected during postmortem toxicology. And I think this is really important to emphasize because as we attempt to address the overdose crisis, we need to ensure we're targeting our interventions in the right place. And this includes also paying attention to the increasing role of stimulants in contributing to drug-related deaths, as well as the non-pharmaceutical, non-prescribed benzodiazepines that have been increasingly contaminating the drug supply. Next slide, please. And finally, just in terms of the impacts of overdose on people experiencing homelessness, this was a place where among people experiencing homelessness, overdose-related deaths increased by 139% during the pandemic. And I think we really need to ensure that we're delivering broad-based supports, including harm reduction, overdose prevention sites, as well as access to low-barrier medical care directly within the sheltering settings and supportive housing settings where people are already receiving services. And now I'd like to turn over to my colleague and co-author on the report, Jess Bashera, who's a frontline worker in Brockville.
Thanks, Jillian. So I'm just going to share some of my experience over the past couple of years It has been quite a journey. And I think in the beginning, like everybody else, there was a lot of confusion. We saw everything shut right down. Our addictions and mental health workers were pulled out of the field. Our public washrooms were shut down. The library was shut down. The Y was shut down. Nobody had anywhere to go. Nobody knew what was going on. The only stability we had in our community was the clinic that people access for substance use. We're really lucky that we have such an inclusive clinic here because it's not what normal clinics are like. We have a nurse on hand through public health. We have a counselor and caseworker who were still, because they were funded through the Addictions and Mental Health Agency, pulled away, but fought to come back after the first few months at home. We have an amazing doctor here who feels everybody, and he's great in our community. And it was actually him who kind of stepped up and brought attention to our community that we were really lacking in a place for people who were experiencing homelessness to be able to isolate because they had nowhere to go at all. We came together as community partners and we all kind of discussed what we needed to do, what the dangers were, what safety measures we needed to put in place. And it came together, but we didn't do it well enough. We didn't provide the right sources, resources for everybody that was accessing the services. And unfortunately, it was the clientele and the people that were accessing it that paid for our mistakes. And I think they're still paying for our mistakes. And that's not fair at all. We started to see things like the dollar store become an essential service, and still our counseling was not considered an essential service. So as a substance user, that just makes me feel horrible. It makes me feel like I'm not included. It makes my peers feel the same way at all. And it needs to change. And that's a big part of the stigma that Jillian mentioned. And I think, the longer we've gone without these resources, people have just assumed that we're doing okay without them. And they haven't come back to us as everything else has begun to open up. And we're not doing okay without them. You can see in the numbers, people are dying. Our overdose rate went up 78% in our community. We saw deaths like we've never seen before. I live in a smaller city, so we'd have a couple of people pass. And then it just became, month after month, week after week, everybody was dying. And, people were experiencing multiple overdoses a day. People were experiencing so much trauma, trying to revive their friends, their peers, their partners, their parents. And there was no help. There was no help. There's still no help. The staff are burnt out. The staff at my clinic are exhausted. They can't take another loss. It's almost gotten to the point where people are putting up a wall, kind of hardening their heart because they just can't take another loss. And it's hard to see people act like that and behave like that because the people I work with are so full of love and so kind, and they need support too. We saw the drug supply become more and more toxic the longer the borders stayed closed. We saw overdoses like we'd never seen happen before and didn't know how to respond to them. We, again, just have lost so many people, and I can't say it enough. There's just so many people we've lost. So many of them were preventable deaths, and it's so unfortunate. When the CERB money came out, I think that there was a lot of attention on the substance user. They're spending all their money on CERB money. They're spending all their money, but we were using substances anyways. And that money just made it a little easier for people. They didn't have to hustle. They didn't have to go out. In fact, it probably made it safer for the community because people weren't out hustling, scamming, doing whatever they needed to do to get the money. But that's not where the attention was brought. As the dope got more toxic, our tolerances increased. We saw the methadone prescribing guidelines change a little bit, but nowhere near what they needed to change. So if people are lucky enough to get into an OAT prescriber that's able to start them off at a good enough dose, they still have limits there and their needs are still not being met. And I think that's really like a common theme, is that regardless of where I turn anymore as a substance user, as a community outreach worker, as a peer support worker, my needs are not being met, and neither are any of my peers on any level. That really needs to change if we're going to get any help at all. If we're going to get any headway in this space, we need support. We need as much support as you can give us. You know, we saw the community respond to COVID like nothing we've seen before. And we've been in this pandemic for years and haven't seen anything like that. We need the same kind of response. We now know it's able. We now know you guys can do it. We just need you to do it. Thank you. And I would just like to acknowledge all the other authors that participated in this report.
Thanks so much, Tara and Jillian and Jess, for covering a lot of data and a lot of experience to contextualize it. And we'll move to our question and answer period for the last 15 minutes or so that we have together. I see actually that our presenters have been hard at work answering some of the questions already, and there's a few that are left to address and some coming in. So I'd invite others to enter their questions, and we'll attempt to address as many as we can. So I think the first one is for Tara maybe, and then if others want to comment. Did you observe different opioids than fentanyl contributing to deaths after December 2020?
Yeah, we definitely continue to see, multiple different types of opioids, both pharmaceutical and non-pharmaceutical opioids involved in fatal overdoses after this time. I think what we have found and what continues to be the case is that it is increasingly fentanyl, and it is predominantly fentanyl, and that trajectory just continues to climb. So before the pandemic, it was around 70% of opioid-related deaths involving fentanyl. We're up to 90% now, and I think as we see the rise in opioid-related deaths, the increases, those incremental increases we keep seeing, are increases that are pretty much entirely, I can't say 100%, but pretty much entirely non-pharmaceutical opioid deaths. And so that's where the growth is, and that's where this crisis has continued to grow, especially as we saw fentanyl enter the market around 2015, 2016. It's just all of those incremental increases are essentially fentanyl deaths.
Thanks.
And if I can just add to that a little bit, I think we need to spend a bit of time thinking about how the changes in the unregulated drug supply are really influencing the way that people are using, and that they're using different drugs differently. So one example about this is that increasingly, due to the presence of atizolam and other non-prescribed, non-pharmaceutical benzodiazepines being added to the fentanyl supply, we see people who don't usually use stimulants starting to use stimulants to try to counteract the extreme sedation that they'll often feel if they have fentanyl that is heavily contaminated with these benzodiazepines. And so there's always obviously been people who've enjoyed the feeling of a speedball, which is where a fentanyl or an opioid is mixed with a stimulant. But that's not what people are describing to me now. What people are describing is that they're worried about being extremely sedated for hours from the fentanyl. And so instead, they're using stimulants prior to using fentanyl to try to counteract this. And so again, I think we're seeing these patterns of change in the way that people are using drugs driven by the unregulated drug supply, and this continuing volatility that is really having strong effects on people that we're not properly taking into account.
Thanks, Jillian. The second question here is, I wonder the reasons for people not continuing OAT treatment. Is it because they're using other substances and told they're no longer able to access it? And then a second part, prescribers may need to push the boundaries in this area as a way of increasing retention. So I wonder maybe first, Jess, if you might want to comment on reasons for not continuing treatment, and then maybe Jillian, if you have insights as well around discussions with prescribers or people's experience with prescribers to address the second part.
So what I have been seeing is that the tolerance that people are experiencing right now, because the drug supply is so potent, is too high for the OAT to kind of match it. And people are starting program and they're trying to get up to their dose, but it's hard to make it in every day in dose. If you miss a couple days, you can't go up on your dose. And it's just too much work for not enough payoff right now. It's just not worth it. People are trying, but it's not worth it.
Thanks, Jess.
Yeah. And I think that there's been some attempt by prescribers in Ontario in particular. There was a new set of guidelines that was released by Medify that was attempting to grapple with this question that Jess is just alluding to in terms of how to meet people's needs in OAT in an era of fentanyl, which has driven tolerance much, much higher. I think that this is, again, a place where we really do need to think through the criticisms that we've been hearing from people who use drugs for years. Even preceding the fentanyl crisis, around the difficulties with dosing schedules, people who have jobs, it's very hard to go to the pharmacy every day, very frequent need for urinalysis in some programs that aren't necessarily following the best practices guidelines. So I think we really need to think about how can we ensure that there's good quality in the treatment programs that are there, while also enhancing the access that people have. And again, here, I really, really think that people who use drugs have been telling us for a long time what would work better for them. And this is where the pandemic prescribing guidelines were interesting, because it was actually an attempt to loosen the take-home dosing requirements for the first time in a very long time. It was kind of a natural experiment, so to speak, to see what effect that would have. And we're starting to have strong data both from Canada, the US, and some European jurisdictions, interestingly, around heroin-assisted treatment, looking at this and finding really that it really improved people's lives and their retention while not having any kind of harmful effects as well. So I think it's important to kind of take that into account a little bit more as we're looking to increase retention in treatment programs.
Thanks, Jillian. Tara, I may put the next question to you. If you have data on the mode of consumption, injection versus inhaled, and maybe change over time.
Yeah, we didn't look at that specifically in this report, but in our report that we released last May, we did look at different modes of drug use. And one of the things that I think ties in with what Jillian described as well is that we are increasingly seeing more and more evidence of inhalation as the mode of drug use as opposed to injection. And if one of the things that I think we then need to consider as we're thinking about what services we provide and how we provide them is how we make sure that supports for inhalation are also incorporated into those environments. And that can be tricky, especially, during a pandemic when we have concerns about spreading COVID, and also need to make sure that we're being responsive to how this issue is evolving and how drug use is changing so that we can be responsive and provide people with the services that they need. So I guess broadly, yes, inhalation is increasing quite a lot. And I think that we need to then be responsive to that and be thinking about how we can be incorporating that into our services. And it's not likely straightforward, but is something that really needs the investment of both finances, which are going to be needed to set these things up properly within safe spaces to use drugs, as well as expansion across all parts of the province.
Thanks, Tara. The next question is addressed to Jess about how peers are best utilized for intervention when respiratory arrest occurs, the point at which a person's heart is not stopped, and there's a window where you can intervene to avert cardiac arrest. So I wonder if you have insights on that, Jess, and then I'll open it up to the other panelists for any other thoughts.
I think we've just had so much frontline experience with what's been happening that we've kind of learned quick ways to, carry quick breaking ice packs. Everybody's trained up on their CPR. We all obviously carry our naloxone. We just do our best to make sure there's always somebody there. So we're trying to make sure people aren't using it alone and that people aren't using at the same time, so that people are awake and ready to help when that comes in. But really it's just the knowledge. And, we've seen overdoses change where people would just drop off to, we had a couple months where people would start to seize. We've seen really a lot of different things. And I think just being around it and knowing what can happen, and what has helped, yesterday is probably going to help again today, has really been our saving grace for PeerWise.
Thanks, Jess. I'll get to the next question, and maybe I'll see if Jillian wants to comment first. So this is about the finding of significant mental illness diagnosed in the past among people who died, and whether there's a good rationale to improve services to this population so that they're in a better position to avoid starting drug use, and psychiatric services and drugs for people with major mental conditions are notoriously inadequate. So I just wonder if you can follow up on some of your previous comments about the complex care.
Yeah, I think that there is enormous challenges in providing appropriate mental health services. And I think that here we really need to focus on trauma-informed services. Oftentimes when you're working with populations of people who use drugs, the levels of significant trauma in people's past are really quite enormous. And one of the things that I've been very worried about in some of my recent research was how this is being compounded by the additional traumas that people are facing due to the overdose crisis. So the traumas of having to intervene in overdoses of your friends and your family members, the traumas from having lost so many community members to overdose. And I think that we're really in a phase right now where people have so much trauma and really no place and no adapted services to try to address this. There's been some really interesting community level programming that's been trying to deal with this. But I think within our mental health system generally, it hasn't been well set up for this. And I think that also as soon as people start using drugs, things tend to get blamed on the drugs rather than seeing people's drug use as a coping mechanism that they're using to try to address significant traumas that they've had or very difficult life circumstances that they're having, like living outside during a cold wave when 40 centimeters of snow has just dumped upon your tent. And so I think we need to think about the ways in which drug use is often functional for people. And we need mental health services that are well adapted to those realities and to really being able to be easily accessible for people and to really deal with the trauma that people are facing. And that's in very short supply, unfortunately.
Thanks, Jillian. I think we have time for just one or two more questions. It's gone by quickly today. The next question, there may not be an answer to this, but I'll see if any of the panelists have insights. Do you know if the methadone guidelines will be permanently changed after the pandemic to allow for take-home medication? So just inviting if anyone has comments or insights on that.
Very quickly, I don't think any decision has been made. Certainly, they're continuing to be implemented right now. And I know in the United States, SAMHSA has announced that they are making some moves towards those changes becoming permanent in the United States. So I think perhaps some people are waiting for more evidence to evolve. And as Jillian mentioned, there are a number of studies underway and just being released that I think are going to give some really helpful information as to how this worked and hopefully help support this continuing in some way moving forward, even as the pandemic subsides to some degree.
Great. And I think the last question we'll have time for today is touching on the issue of chronic pain in the data. And I wondered, Tara, if you might want to take this. So was there a statistically significant number of chronic pain patients with long-term prescriptions noted in the analysis? And it's an idea that's been repeated in healthcare circles, but maybe understanding the study if it does or does not support this.
We did look at chronic pain diagnoses and found that just under a third of opioid-related deaths during the pandemic occurred among people who had some form of a chronic pain diagnosis. It did decline during the pandemic. I think that just shows that it's decreasingly co-diagnosis among people, but certainly there's a high prevalence. When we look at people with both chronic pain and a diagnosis of opioid use disorder, that's actually pretty high as well. It's around 15 to 20%. So I think that's important to note too, is we can't just consider, sometimes there's this desire to kind of separate these two populations into people who have an opioid use disorder and people with chronic pain. And I think there's also a lot of overlap in terms of people who use drugs and who also have chronic pain diagnoses. And so we need to also think about how our responses are being built in kind of across the spectrum of the huge diversity of people who use drugs in many different ways.
Great. Thanks so much, Tara. And so with our last minute, we need to come to a close, but thanks so much everyone for joining for discussion of this new report released today. Thank you especially to our speakers, Tara, Jillian, and Jess, and everyone for their participation. There's lots of questions and seeing we weren't able to get to, but we covered quite a few. So it's really great to have so many people given the demands of where we're at today in our lives and our work to be able to free up some time to join. You'll receive a rounds survey for feedback, and so if you can watch for that and fill it out. And then just lastly, if you're looking for upcoming presentations for PHO rounds, it's on the Public Health Ontario website on the events page. And thanks so much everyone, and have a good day.